You can't get rid of me. I'm here on behalf of my Italian collaborators who had the last minute to cancel the participation. So I'm here to present a simple study compared to whatever we have seen up until now. So sit back and relax. And it is about acute phase response, zoledronate, and patients with inflammatory rheumatic disease. So how do we put everything together? You all are very well, at least the clinicians, very well aware of the flu-like symptoms, that is the myalgia, the pyrexia, which follow the first administration of a nitrogen-containing bisphosphonate, particularly intravenously. We see that within 48 hours in about 50 to 60% of the patients, and it is associated with typical changes, namely a decrease in lymphocyte count, an increase in C-reactive protein, and an increase in interleukin-6, something we have established already about 25 years ago. And this effect is transient, and usually it is not repeated upon a second infusion, or it is usually milder if it comes back. Now, the response, the acute phase response to zoledronate has been very well and detailed characterized in osteoporosis, but in inflammatory rheumatic diseases or glucocorticoid-induced osteoporosis, this has not been done, which is quite surprising, although, of course, in the Horizon trials with zoledronate, either in postmenopausal women or in GOP, the symptoms appear to be of the same frequency. So this is a first question. What is currently the thinking about the cause of the acute phase response to nitrogen-containing bisphosphonates? We do think that it is related to their molecular mechanism of action, which is the inhibition of farnesyl pyrophosphate synthase, an enzyme in the mevalonate pathway in peripheral blood monocytes. So by the inhibition of the farnesyl pyrophosphate synthase, metabolites upstream are being accumulated, and one of those, isopentenyl pyrophosphate, is being accumulated, and this particular metabolite can react with receptors in T cells, particularly the gamma delta T cells, increasing their activation and proliferation and leading to stimulation of pro-inflammatory cytokines such as IL-6, but also TNF-alpha, which, as we said, are considered to be the main drivers of the acute phase response. However, zoledronate has been shown in a study in vitro that it may have an effect in the expression of immunoregulatory proteins involved in the activation of T cells, and one of those is CTL4, cytotoxic T lymphocyte antigen 4, which has a membrane-bound and soluble form that can be involved in the activation of the T lymphocytes, and actually decreases also TNF-alpha. In addition to that, it is currently one of the therapeutic targets in rheumatic diseases, and there are at least 2 factors that target this particular molecule. And it has even been proposed, the soluble form, it has been proposed as a marker of inflammation in these diseases. So therefore, what we did was to had a study with 2 objectives: to investigate the characteristics of acute phase response in postmenopausal women with inflammatory rheumatic disease who were treated with zoledronate, and the second to evaluate the potential relationship between soluble CTL4 and the development of acute phase reaction in response to zoledronate. We included postmenopausal women with inflammatory rheumatic diseases on treatment or not of glucocorticoids with one or more prevalent fragility, fractures, or glucocorticoid-induced osteoporosis, and to receive 5 milligrams. The only exclusion criteria were previous treatment with ZOL, treatments that may affect CTL4, of course, glomerular filtration rate less than 35 ml per minute, and use of acetaminophen or NSAIDs within 7 days before the infusion. Now, so we gave during admission 5 milligrams over 1 hour, and we took auxiliary temperature every 6 hours the day before, and then the following 3 days following the infusion, and patients completed a visual analog scale every 12 hours from day -1 to day 3, and the definition that we used for acute phase response was the rise in auxiliary temperature above 38 degrees at any stage after the infusion, and within 48 hours, and an increase in the musculoskeletal pain by at least 10 millimeters. Serum soluble CTL4 was measured at baseline, 24 and 72 hours by specific assay. So we included 10 women with various diagnoses. So here, I don't want to discuss, the range of diagnosis is shown here. They were all obviously postmenopausal. 8 were using prednisone, and a few had vertebral fractures. Now, 5 of these women developed acute phase response, shown in green, and 5 did not, so very nicely, 50%, so exactly what you see in postmenopausal osteoporosis. So in other words, it didn't matter whether they had inflammatory disease or whether they were receiving glucocorticoids, because don't forget that prednisone is one of the tools we have, the weapons we have, to treat very severe acute phase response. Now, when we look at a couple of characteristics which may be related to the development of acute phase response, we see the age was exactly the same, because usually younger patients are more prone. 25-hydroxyvitamin D levels that have been reported to be associated with acute phase response to bisphosphonates were identical, and glucocorticoids were used just by 4 patients in each of these groups. When we look at the group with acute phase reaction, we saw the response expected to see, so an increase in granulocytes, a decrease in lymphocytes, and an increase in CRP compared to the basal levels. In contrast, there were no changes in the 5 women who did not have an acute phase response. So everything up until now is perfect, nice, and so it fits entirely to the picture. What happened now to the soluble CTL4? Soluble CTL4 now in the whole group of patients show a dramatic decrease within at 3 days. There was a progressive, and then it nearly got to 0 at 72 hours, and there was absolutely no difference between the patients who had and those who did not have an acute phase response. So contrary to our hypothesis, there was no difference between the 2 groups. However, there was this dramatic decrease, which started now a new way of thinking. As a first experiment that we performed, we went first in vitro, and we tested peripheral blood mononuclear cells from donors, stimulated polymorphonuclear cells from healthy donors. Here are stimulated, and then we treated these cells with zoledronate and put them in culture for 3 and 5 days, and took the measured in the supernatants CTL4, and you can appreciate here the dramatic, again, decrease also in vitro, which corresponds entirely to the in vivo findings. And there is currently, of course, a series of experiments being performed in order to understand how perhaps zoledronate may be involved with this response. So, in summary, ladies and gentlemen, acute phase response to intravenous zoledronate occurs with similar frequency in patients with inflammatory rheumatic disease, and glucocorticoids do not modify this response. Soluble CTL4 is not related to the occurrence of acute phase response following zoledronate, and the circulating levels decrease dramatically within 72 hours following the infusion. And finally, zoledronate decreases also soluble CTL4 in cultures of monocytes in vitro. So these these results lead to the hypothesis that zoledronate may exert, apart from its known action, an immunoregulatory effect, which is independent of its action on the mevalonate pathway, and may have another action. I mean, to take further the discussion we were having yesterday with Dr. Reed about trying to understand pathways and so on, bisphosphonates, particularly zoledronate, and today also with the story of myeloma. So we might, and cancer, we might be, in front of some action which may be able to explain some of the effects of zoledronate. I hope soon to have some more information to communicate to you. Thank you very much indeed for your attention.
There was a publication that if we administer a dose of cortisone intramuscularly the day before the administration of zoledronate, it will eliminate the acute phase response.
This is not exactly.
So
I mean, this gentleman has shown something different. It was your paper, wasn't it? Yeah.
And the question is, in rheumatic real life, we use a dose of prednisone of 5 or 7.5 milligrams. But if we administrate intramuscularly vitamethasone, then the dose is 5 to 10 times more.
Yeah.
Maybe you need this dose to eliminate.
I accept what you're saying. However, there are, remind me, and you gave 10 milligram dexamethasone, if I remember? 4. Okay. He didn't find any changes. And there are others, as you said, which respond to high doses. This is absolutely correct. We don't know who and what, but in clinical practice, that is what we all do. If we are faced with a very severe reaction that does not respond to the NSAIDs, then we go there. But as you can see, I mean, to me it was a little bit of a surprise to find exactly the same incidence in this particular population.
Another question, maybe Dr. Lems would like to comment on CTL4. We used monoclonal antibody or against CTL4 in rheumatology.
Yeah, but you're using two things. I mean, if you start talking about that, you have to be very careful because CTL4 is very confusing because the two different antibodies, the two different agents that are available are fundamentally different. One is the CTL4 itself, the other is the antibody. So please.
And the CTL4 is decreasing, so that would be difficult to use that. I have another comment because it's puzzling why rheumatologists have not found it acute facial reaction in their patients so far. And probably one of the explanations could be that your definition was a rise in temperature of 1 degree and an increase in the visual analog score of 1 centimeter. And that's probably,
by the way,
probably that's acceptable for a lot of patients with rheumatic diseases, not a really warning signal of musculoskeletal pain, in contrast to postmenopausal women. So I think that could be the explanation for...
Okay, you're right, but in this particular one, the mean increase in the visual score was 4.8, and we had a couple of very, very severe ones with the muscle pains and everything. So the typical thing we see in postmenopausal osteoporosis, and this was a surprise for us. Yeah?
Thank you very much. I think there are no further questions.
Good. Don't go away. Yeah?
And indeed, I would like to close this very exciting sessions, and then we